Good afternoon and welcome to the second in a series of our 4 RISE webinars on physician wellness. My name is Carolyn Gahn. I'm your Executive Vice President. I believe I have everyone's microphone muted except you, Dr. Knight.
All
And
right.
yes, and I do request that everyone would please use the chat box this afternoon for 2 purposes during our 30 minutes together. First of all, we do invite you to use that chat box to provide your name if you've not already done so, and that of any other KAFP member in the room. We will turn in your CME for you for this half credit at the end of today's webinar. Secondly, we ask you to use that chat box to submit questions during the course of the webinar, and Dr. Knight will answer those at the end. So now to our presentation. RISE stands for Restore, Invigorate, Strengthen, and Energize, and that's our hope for this webinar series. Today's topic is Physician Health First, AAFP Physician Health and Wellbeing Resources. Dr. Cliff Knight is a family physician who is the Senior Vice President for Education at AAFP. Prior to that time, he was a family physician in Indiana for 25 years, and we've welcomed him to Kansas now for several years. At the Academy, he oversees all of AAFP's organizational activities that relate to medical education, including continuing medical education like today, journal media, and then in addition, he is focused on promoting patient safety, clinician well-being, and use of performance improvement tools and techniques to improve healthcare and health outcomes. He leads the AAFP's initiative on improving family physician well-being and professional satisfaction. And he's also on the steering committee for the National Academy of Medicine Action Collaborative on Clinician Well-being and Resilience. That is quite a name for an organization. So, Dr. Knight, with no further ado, I will turn it over to you at this time. Thank you.
Great. Thanks very much, Carolyn. And are you able to hear me okay? Is that good? Yeah, good. Well, yeah, welcome. I'm going to go through several slides, hopefully pretty quickly, and then give you a chance to ask questions and have some discussion around this. And so I always like to give my disclosures. I have no conflicts to disclose, but I do think it's always important to point out that I am employed full-time by the AAFP. I'm no longer in clinical practice. As Carolyn mentioned, I'd been in Indiana my whole life before I came to the Academy 4 years ago, and I practiced in a town of about 2,000 for a few years after finishing residency. And then I have spent most of my career in education. Was full-time with family medicine residency program in Indianapolis and served as program director there. And then after that, I was in more of a hospital administration role, and for 7 years was the vice president of medical affairs for 2 hospitals in Indianapolis. In the last 5 years I was there, I was chief medical officer for an 8-hospital system in Indianapolis. And so I think I have several different perspectives that I bring to this, and really feel very strongly that it's a real risk to patient quality of care, safety, and access to care if physicians are burning out and leaving practice. And unfortunately, we hear those stories quite frequently. Last week, I got an email from one of our members in Alaska to let us know he wasn't going to be renewing his membership dues this year because he became burned out and left practice, and really was leaving a lot of people in his community unserved. And so, I think this is really important for the physicians involved, but also, for the patients and families and communities that we serve. And so this is a high priority at the AAFP. In fact, I'm a little struggle getting the slides to move. Sorry. There we go. And so, for this session, I want you to be aware of several factors that contribute to physician professional satisfaction, well-being, and burnout. I want you to be able to, again, sorry, I'm not able to get the slides to advance right now. Oh, there it went. Okay, I want you to be able to utilize a framework that we're using called the Family Physician Ecosystem as you think about developing a plan to improve both your well-being and the well-being of other family physicians. And then I also want you to be able to understand the components of the AAFP's plan to improve family physician well-being and some of the resources that we offer. I continue to struggle with, oops, here we go. All right. I was going to mention, we have 4 top priorities at the AAFP. First is payment reform. We believe that primary care is under appreciated in the United States, and that's evidenced by the fact that our payment system undervalues primary care. So one of our top priorities is to increase payment to primary care. The second is to help our members make a transition from a fee-for-service environment to a pay-for-quality environment. So that's one of our other primary goals. And a third one then is to be a leader in addressing health equity issues and diversity. And then the fourth is that the AAFP will assist our members in achieving well-being in order to enjoy a sustained career in family medicine. And so our board of directors in 2016 identified this as one of our top 4 priorities, and I serve as the executive sponsor for this effort for the AAFP. I apologize, I continue to have trouble advancing. So what we hear, as we started to really dive into this a few years ago, we heard loud and clear from our members, don't try and fix me. I'm not the one that's broken. It's the system that's broken. So, fix the system. And also, this isn't what I signed up to do. I talk to physicians all the time to say, I went into medicine to help people and to really focus on taking good quality care of people, taking care of people. But I spend my days clicking buttons and spend my days in front of the computer and typing in information. And it feels like I'm really not doing what I signed up to do, what I really chose to go into medicine to do. And finally, I do apologize. I am just not having any luck moving from one thing to the next. There we go. And the next thing we hear then is, help me, I'm drowning in this crazy system. And so at the same time that we're trying to fix the system, we are trying to provide assistance for folks so that as they address the hectic environment that they're practicing in, that they find assistance in improving their professional well-being and their overall satisfaction. And so, so this is this presentation is focused on well-being and professional satisfaction. I do like to start out by mentioning, so what is burnout? And this is typically thought of as a triad, a syndrome with 3 elements. One is the loss of enthusiasm for work or emotional exhaustion. Second is a feeling of cynicism or depersonalization, like just don't care as much about the work that you're doing or about the people that you're serving compared to previously. And this low sense of personal accomplishment. So that's the triad of burnout that when we use that term. Well, and so after having had discussions with our members over the last few years, this is the formula for distress that I hear from so many of our members, that the combination of the EMR being RVU driven it just leads to feeling sad. This competing priority of try and see more patients and do more, but at the same time being slowed down by the inefficiency of the EMR. And this is the number one thing I hear from our members that is leading to their distress. Next slide, please. And the AMA has done a lot of work on this, and they summarize some of the drivers of burnout as high workloads. So again, RVUs play into that. Workforce inefficiencies, the increased time spent in documentation, and then a sense of loss of meaning at work, and for many, a sense that medicine has shifted from values of taking the best care we can for our patients to more of a corporate approach or more corporate values. I think it's important to recognize that many physicians feel socially isolated at work. They just don't feel connected to the community of their peers that they really need and value. Next slide, please. And then, what this leads to is a combination of professional and personal distress. Burnout is technically it's a work-related condition, but certainly can affect your personal well-being as well. But from the patient standpoint, it can lead to decreased quality of care and increased errors, as well as decreased patient satisfaction with the experience that they have, the interactions with their physicians. And it also then decreases productivity and professional effort, because we know that physicians who are burned out typically at least decrease their workload, but many end up leaving medicine. And it certainly leads to increased physician turnover within organizations. And then the personal aspects can lead to difficulties with relationships, alcohol and substance abuse, and in worst cases, depression and suicide. And it's pretty well known that the rate of suicide amongst physicians is significantly higher than the general population. You could go to the next slide, please. And so here's the most recent burnout data from Medscape. Medscape does an annual survey of physicians across all specialties, and unfortunately, family medicine continues to rank right up at the top as far as the rate of burnout amongst physicians in family medicine. And I think it's really important, though, for us to try and understand some of the nuances of this. And what we do recognize is that for several years now, the Medscape data has shown this gap between women in medicine and men in medicine and the rate of burnout. And again, this year, there was a 10% higher rate of burnout in women in medicine than men. And this continues to be an issue, and we've seen it within our own internal data as well. So that's the burnout side of things. But how about happiness? What about physician happiness? And in the same study that Medscape does, they ask about happiness both outside and at work. And outside of work, 50% of all physicians across all specialties report feeling extremely or very happy. And in family medicine, it's slightly higher than that. It's 51%. Next slide, please. But when you look at it at work, there's a significant difference from outside of work. And so again, this was the percent of physicians in this study that reported feeling extremely or very happy at work. Highest was ophthalmology at 37%. I would say that if the best we do in medicine is that a third of physicians in any given specialty are happy at work, that says a lot about what is systematically sort of beating down physicians. Unfortunately, family medicine is right near the bottom. At only 22% of family physicians report feeling either extremely or very happy at work. So when we look at the next slide, I think that this is really a key concept here, because I don't believe that our goal should be to just decrease burnout. I think it really is about trying to help people find true happiness at work. And so in that study, if 22% of family physicians said they were happy at work and 47% reported burnout, that leaves this gap in between of 31% who aren't burned out, but they're not happy either. And so, go to the next slide, please. I think the important concept here is that the lack of burnout is not the same as well-being, and it's not the same as happiness. And so at the Academy, what we've adopted is an approach that we're really going to focus on improving well-being and professional satisfaction, not simply just decreasing burnout. We believe that if we improve well-being and professional satisfaction, that burnout will decrease. But I'm not sure that the opposite would be true. If we just tried to decrease burnout, that happiness or well-being would increase. Next slide, please. And so this past year, the Academy did our first well-being survey of members. And we plan to do this each year. We do a select about 5,000 members that we include in this survey. And so we'll repeat that in June of this year. But in 2017, we did our first one. And what we found when we asked the question, would you choose to be a family physician again? 55% of the respondents indicated that they would definitely be a family physician again. 22% said no, and there's this group in between that don't know. And again, I think this correlates with that group of they're not happy, they're not burned out necessarily, but they're not happy either. And again, with our data, we see that same gender gap between women in medicine and men in medicine, that there's a lower satisfaction amongst women in family medicine or those that would state that they would choose to be a family physician again. Interestingly, when we sliced and diced this a little bit, we found that those physicians who have been in practice the longest in this survey were actually the ones that were most likely to say that they would choose to be a family physician again. And there's a couple of theories on that. One is that the ones that were unhappy left practice by that point in their career. But the other theory is that those physicians practiced at a time where they had a bit more autonomy over their practice and a greater sense of satisfaction from that standpoint. Now I want to talk a bit about the family physician ecosystem and this framework that we're using to approach improving family physician well-being. And first, we look at the big picture. So if you click ahead, please, Carolyn. The big picture is the health system level, and those are the things, the requirements, the regulations that that folks seem to feel they have no control over. Next level then is at the organization. We know that 2/3 or more of our members now report being either employed by part of by an organization, or certainly we know that even physicians that are independent are part of hospital medical staffs and other organizations that impact their sense of well-being. Next then is at the practice level, and that's where you spend your time seeing your patients every day, and the routines within the practice that can affect your well-being. And then there's the individual level, and those are the individual behaviors and habits that you have that impact your well-being. And finally, the fifth level is a little harder to describe, and that's the physician culture that we were all trained in and that really impact how we look at our own well-being, and often feeling more comfortable with self-sacrifice than with self-care. And so just to touch on each of these just briefly, on the next slide, you'll see that one of the things that we're doing at the AAFP is really promoting a major change in the payment system. We believe that fee-for-service and that pressure of seeing more patients and volume-based is one of the root causes of dissatisfaction. So we are moving forward with an advanced primary care alternative payment model that we are proponents of. And if you read Sean Martin's blog, In the Trenches, he did a blog just yesterday updating this. And I'm not going to go into a lot of detail on this other than to point out that really the approach to this is a blended payment model that includes payment for global care of patients, population-based payment, as well as some performance-based incentive and a fee-for-service component for those services that are kind of out of the typical scope of the global payments. And at the next slide, you'll see one of the real advantages to that is that because it is focused more on global payment, it really reduces the need for the evaluation and management documentation guidelines. So if you click a time or two again, you'll see that that'll be highlighted there. That in this model, a beautiful thing is the documentation guidelines really allow you to focus more on documenting what's important from a clinical standpoint rather than having to document all the things that you do right now because of billing requirements. The next slide then this talks about at the organization level that we know there is a business case for investing in physician well-being. This was printed in JAMA Internal Medicine last September, and the evidence suggests that improvement is possible, investment is justified, and the return on investment is measurable. On the next slide, really points out that it typically costs somewhere between $500,000 and $1 million to replace each physician who leaves an organization because of lost revenues and because of recruiting expenses and the decreased productivity that goes along with that, and that it has significant effects on quality, safety, and patient satisfaction. And so, one of the things that we are really, the message that we're trying to send to organizations is that investing in physician well-being is the ethical and physically responsible thing for an organization to do. Next then is just a brief, and you can click a couple more times if you would, Carolyn, that one of the things that does lead to distress is when the demands that are placed on you in practice outweigh the control that you have over your practice and outweigh the support that you have. And so the bottom line is that support and control together, i.e. resources, to allow you to really accomplish what the demands are on you, those are so important to help the stress from outweighing the success that you're able to have. And next then is an article I would call your attention to that is in the current issue of FPM, Family Practice Management, and it outlines a team-based care model that Corey Lynn, a family physician in Colorado, talks about how they've implemented this in their practice and how they've spread it to additional practices within their system and the benefits that they're seeing of that. On the next slide, it the overview is that there's increased, and so this is based on team documentation. This is using medical assistants really to do much of the non-clinical work so that the physician's able to more focus on the clinical aspects. And in this model, it showed increased patient satisfaction, increased physician satisfaction was approximately cost neutral at about 2 additional patients per half day, and it significantly decreased the work after clinic, the WAC. And in fact, in most studies that have looked at team documentation or using scribes, it decreases the physician's documentation work by 1 to 2 hours per day. And so as we've done sort of informal polls on this, find that about 10% of family physicians are using team documentation or medical scribes. And one of the things that we would really like to see that is instead of being able to utilize team documentation or a scribe as unusual, we really want this to become the norm and part of the routine way that you practice, so that it really does decrease that amount of work after clinic, so that you're able to finish the day when you've finished seeing patients and not have to go home and do an additional 1 to 3 hours of documentation work. The next slide, then this just talks about the culture again that we've all been sort of programmed to accept self-sacrifice as sort of the honorable price of admission to being a physician, and that self-sacrifice a lot of times outweighs self-care, and so we're really working to try and change that message that really taking care of yourself really allows you to do the best that you can for your patients as well as for your personal life, and that it is important and it should be a priority to provide self-care. So if you'll move to the next slide, I know we're kind of getting to the end of time because I wanted to leave some time for questions, but just wanted to let you know what the AAFP is doing. We released our portal at aafp.org last fall. And I'll talk a little bit more about that. We have a well-being planning tool that's going to go live and should be available on April 11th this month. That's based on the 5 levels of the ecosystem that I outlined. We have our first conference coming up. We're working on chapter workshop series. We have ongoing articles in FPM, and we've made this an area of emphasis at FMX the past few years, and we'll continue to do that this year. And then, as Carolyn mentioned, we are a co-sponsor of the National Academy of Medicine Action Collaborative on clinician well-being and resiliency. So in the next few slides, I'm going to highlight just a little bit on those, and these slides will be available to you so you can find it. But our portal is at aafp.org/mywellbeing, and we have put many resources, links to many resources on the portal there. On the next slide, just to highlight, we've had over 1,400. Now these numbers are from the end of January, so they're actually much higher now. But we've had over 1,400 of our members complete the Maslow Burnout Inventory. That's a online free assessment of your risk for burnout, along with some analysis and evaluation as far as what you could consider doing to address your risk of burnout. And then there's multiple articles, and this just shows how many downloads we've had on various articles that are on the portal. The next slide then highlights a bit about our new well-being planner that's going to be available April 11th. And the idea there is it just gives you a chance to organize your thoughts and develop a plan on what you want to address to try and improve well-being for yourself and for family physicians in general. But it lets you organize resources, save articles to go back and read later, opportunity to set goals and those sorts of things that you may want to track over time. And so we hope that our members will find that very helpful. Next slide then is just to let you know that we do have our conference coming up. It starts 2 weeks from today. We have 450 registrants for that. When we decided to do this conference a couple of years ago, we weren't sure anyone would show up. So it's been really gratifying to us to find that there's a high level of interest. And the next slide just shows, again, our approach is not just to address burnout, but to really help people to feel well and thriving. And the course chairman for our conference is Dr. Mark Greenewald, and he's done a lot of work on this and will continue to help us at the Academy as we develop our resources. And a couple more slides. We'll open it up. Again, the National Academy of Medicine has an action collaborative, and if you go to the next slide, last week they released a knowledge hub, and that's at nam.edu/clinician wellbeing. And whereas our portal is very specific for family medicine, the National Academy of Medicine is really, they have resources for nurses, pharmacists, other clinicians, as well as physicians and physicians in training. And so again, if you're looking for resources, I would encourage you to look there as well. And the AAFP has been a significant sponsor there. Next slide then is, I think, just a wrap up that, again, from discussions with physicians over the last few years, this is my summary. It all boils down to feeling a sense of connection, meaning, and purpose to what you're doing. It's being given those resources to make the difference so that you don't feel out on your own without the support that you need. It is there's an important aspect of respect here, that family physicians need to be respected by the system and paid appropriately for the value that family physicians bring to the system. And then it's a lot about relationships. It's relationships between physician peers. It's a relationship to your staff, your patients, your communities, and certainly your loved ones as well. And that's what really rounds out a family physician's well-being. So next slide, I think, is it's just a call to action. And if you click it one more time, our approach here is that there are no bystanders to trying to improve this. We can't wait for the government to fix this. We can't wait for the insurance companies or the EHR vendors to fix this, or the hospital systems. That it really takes motivated family physicians to challenge the organizations and the practices that they're in to make those changes that will impact the well-being of physicians and other clinicians on behalf of the patients and communities that we serve. And I think that's it. There's my contact information. Please don't hesitate to reach out to me. And I'm going to try and find the chat box. Mine disappeared. There we go. And so we're down to our, well, Carolyn, do you want me to address any of the questions, or do we need to sign off at this point?
I do respect the fact that we have kept you 31 minutes rather than 30. And so if anyone does need to sign off, please go right ahead. Dr. Knight, if you have another moment and can address the question that was submitted regarding repercussions in general physical health of physicians, I think it would be appreciated.
Yeah, I think that's an important, so the question is, what about the general physical health of physicians? I think it's always ironic that here we are, we go to medical school, we learn all about the normal and abnormal functioning of the body, and yet, again, the culture that we're trained in, I believe is where it starts, is that we are, for lack of a better term, we're programmed to believe that it's more honorable to sacrifice ourselves, including our physical health and physical well-being, and in order to be a good physician, or to be to be worthy of being a physician. And I believe that we need to, as a community, reach out to support each other and help each other realize that it needs to be a priority for you to take care of yourself. I compare the physician culture with the airline pilot culture. In the pilot culture is that their first responsibility is to maintain their physical and mental health in order to be able to provide the best professional service that they can on behalf of the passengers that are flying in the plane every day. Later today, I'm going to be flying from here to one of our state chapters for a state chapter meeting. And, I make an assumption that the pilot up there behind the door that I can't see is taking care of him or herself, keeping physical fitness and mental fitness a top priority so that they can safely provide care or service for the passengers they're flying. I don't understand why in medicine that hasn't been emphasized more than it has been, and why in medical school quality of life measures go down precipitously during medical school and never really get back up to age-matched, education-matched cohorts. There's something that we systematically do in medicine to decrease our quality of life, including our physical health. And so it absolutely is an important repercussion of this, is that physicians need, it shouldn't feel like a luxury or a guilty pleasure to take care of your well-being. That should be a given. It should be an important part of our professional responsibility, and we shouldn't have to apologize when we want to take care of ourselves, because it really does allow us to do serve our mission better if we're in good shape. So we have to change that approach, and part of that is that we have to be to send that message to each other. We need to be encouraging of our peers that it's okay to take care of yourself physically. I hope that answered the question.
Absolutely. Thank you so much. We did have one other question submitted regarding data on rates of obesity, HTN, heart disease, and FPs. And if that's
I'm not sure that I've seen any data specific to family physicians, but in general, I think there is some data that physicians, again, are, it's interesting that I believe that physicians' life expectancy is higher than the general population, but I've not seen specifics of those questions. So I don't want to make anything up because I really don't think I know a specific answer to that.
Okay. Well, thank you.